5 mistakes you could be making when you're healing from SIBO. Hi, I'm Dr. Mona Morstein at drmonamorstein.com. Welcome to my channel. Please click subscribe and let's dive in to today's topic, which is 5 mistakes you could be making when you're healing from SIBO. Now, SIBO, small intestine bacterial overgrowth, is unfortunately pretty common, kind of under the umbrella of IBS. IBS is 35% of visits to a gastroenterologist. And the statistics are about 65% of IBS cases are SIBO. Right? If you're having chronic bloating, if you're having diarrhea or constipation, or if you're having a distension, GERD, flatulence, just everything doesn't sit well in your gut, even water, then you really need to be seen and tested for SIBO. Now, SIBO is common, but it is fairly infamous for sometimes being difficult to treat, for its coming back, and for continued symptoms. There are 5 things that I'm going to talk about today that are mistakes that may be happening with either you or your practitioner in your treatment of SIBO. So let's dive in. What's the first one? First one is getting diagnosed correctly. What do I mean by this? SIBO can only be diagnosed by a breath test. Unfortunately, there are many practitioners now who are doing stool testing and seeing, oh, look, you've got a lot of Methanobrevibacter smithii, which is a type of archaebacteria that causes methane SIBO, but it's in the stool, it's very high, so you've got to have SIBO. No, that just means you have a lot of that bacteria in your gut from that stool sample. But SIBO is only diagnosed through the breath. Now, there's another kind of SIBO called IMO, intestinal methanogen overgrowth, which is promoted by Dr. Mark Pimentel. A little controversial, but it's out there in the SIBO world. You still can't really diagnose that through the stool either, even though it's showing colonic overgrowth of the Methanobrevibacter smithii, but through the breath, not through the stool. So first thing, get correctly diagnosed. Now, what breath test should we use? Basically, the key one is called a Quintron machine from a lab that does regular calibrations, right? I use Aerodiagnostics. There is another one called TrioSmart, and that one they say does the hydrogen and methane that they all do, but they say they throw in also hydrogen sulfide, which is a third gas of SIBO. So that's another test. There's also the food marble test that you can buy and do yourself, but has to be analyzed by a physician. And the last one that I personally say to avoid is Commonwealth, which is a different kind of technique that I don't personally think is worth doing, right? So testing correctly. You've done a correct breath test with a good lab. Now we know you have SIBO. Number 2, retest after every treatment. It's amazing to me how often this does not happen. That people will get a treatment, right? A person gets SIBO, they get a treatment, and oh, I still have symptoms. Well, let's just give you the same treatment again or again, and people aren't getting retested. That is a major mistake. We need to retest for 2 main reasons. One is, do you still have SIBO? SIBO in and of itself can be eradicated, but you can still have some symptoms because you still have leaky gut. You still don't digest your food well. Maybe on top of that, you do have some colonic bacteria or a fungal overgrowth that's common with SIBO that's causing other symptoms that needs to be addressed. Not having a clearance of symptoms does not mean you didn't eradicate SIBO. So we do need to know, we did a treatment, is your SIBO gone? 2, we also need to know if you did a treatment and we retest, if you still have SIBO, the test can help us understand, was this a valid treatment for you? Like if you started at your numbers at 100 and you went down to 30, well, that still could be a positive test. It is positive, but that was an amazing improvement, and this protocol was effective for you. Versus if you start at 100 and you do the protocol and you're still at 100, it didn't work. you can't just keep using the same treatment. We've got to redirect an entirely new protocol for you to try to get a protocol that is effective for your eradication, right? So two main reasons that, yes, I get financially it can add up, but this is a serious condition. It's causing serious quality of life problems. We definitely need to retest and gain that data. Now, the third mistake is eating a FODMAP type restrictive diet for a long time. Now, the FODMAP diet, right, the fermentable oligosaccharide, monosaccharide, and polyol diet is really kind of a diagnostic diet where people with IBS type symptoms go on the diet and see if they get improvement, right? It's designed for someone to live on for 5 or 6 weeks. It's not designed to be lived on for a year or 2 or so forth, because it's really not that healthy a diet for the gut long term. So the more we stay on really, really restricted diets, we can weaken the integrity of the gastrointestinal tract, weaken the beneficial bacteria, so that it just takes longer to rejuvenate it and heal it even after the SIBO is gone, and bring it back to life so you can go back to that normal diet. So just watch following very restricted diets for long term. Fourth, okay, we've got to add a prokinetic after we treat SIBO and eradicate it. Now, gastroenterologists, they don't know this. And unfortunately, many other practitioners don't. But when we eradicate SIBO, it has a high rate of recurrence. Remember, in SIBO, the main illness is the lack of movement of what we call the migrating motor complex, which is the nerves that stimulate these cleansing waves through the small gut and keep it clean and healthy. And if that's not going forward, it's very easy to backwash bacteria from the from the colon into the small gut, or even have the minor bacteria in the small gut overgrow. So we have got to treat the SIBO, eradicate it, and then put you on a prokinetic to make sure those waves are happening. Even if you have diarrhea, you got to go on a prokinetic. And certainly if you have normal stools or constipation. Now, prokinetics can be supplements, and there's weaker and stronger supplements. They can be compounded medication or just regular prescription drugs, right? So you've got to work that out with your medical prescriber to figure out which is best for you. But you got to go on a prokinetic, and you got to stay on it, right? Recurrence also tends to happen when a person didn't get a prokinetic. They got a prokinetic but stopped it after a couple of months. They got the prokinetic but still got it back because it's not a strong enough prokinetic. Or they got a good prokinetic but the condition they have is still going on. But it all does rotate around prokinetics. The last one. So one of the ways that we eradicate SIBO is with antibiotics. And we use rifaximin, which is a great antibiotic, right? Because it really only works in the small gut. It has very little action in the colon where the microbiome is, the beneficial bacteria. It doesn't get absorbed into the body. It doesn't cause resistance. That's why physicians like me, I don't like antibiotics, but I'll use Xifaxan because it's so safe. Now, Xifaxan for itself can be used for hydrogen SIBO, but for methane, it has to be combined with something else. And it's oftentimes combined with another antibiotic. Now, there's basically 3 choices. One is Flagyl, also known as metronidazole. One is neomycin, and the other is Alinea or Nidazoxanide. The problem is most people get metronidazole or neomycin. Problem with these antibiotics, they're broad-based antibiotics that will destroy your gut microbiome. All of the beneficial bacteria in the colon, they can be damaged by these antibiotics. So to me, it's a little ironic. We're so focused on treating the SIBO and getting your gut healthy, but we're going to do it by really harming your beneficial bacteria that can take a year to recover from, right? So I'm not really much of a fan of those two antibiotics. Metronidazole is also upsetting to so many people's gut and can give a really nasty taste in the mouth. And Alinea can cause ear disease. And I've seen it irritate the ears in patients. Not using it. Now, the third one is Nidazoxanide, Alinea, and that's generally an antiparasitic. So it's not a broad-based antibiotic and doesn't wreak the havoc in the colon that those other antibiotics do. Now, it is designed to be used twice a day for 3 days as an antiparasitic in the States. But we want to use it for 2 weeks. It's ridiculously expensive. So oftentimes, like with rifaximin, we're going to order Alinea or Nidazoxanide from Canada. I do it all the time. It's ridiculously cheap from Canada. So those are 5 main mistakes: diagnosis, retesting, not doing restricted diets too long, adding in the Prokinetic, and being careful about the antibiotics you use. So I hope this was helpful. For more information, I put together a free guide that you can get in my bio below. It's called 4 Essential Ways to Eliminate SIBO. Hope you enjoy it.